Here's a nice vascular case. So pretty obvious findings here. Very dilated main and branch vessel pulmonary arteries, even on this non-contrast study. If we look closely, we'll see there's some areas of eccentric calcification, which at first I wondered if maybe these were just lymph nodes, but they do look like they're eccentrically located within the pulmonary artery walls themselves. Probably most convincingly down here. I think other areas you might quibble, where there's a calcified lymph node in there or not. There's also, even on this non-contrast study, obvious contour abnormality here of the heart. The right heart looks obviously much larger than the left aspect of the heart. And there's a small pericardial effusion. If we look at the lung windows, we see there's diffuse ground glass opacity, but with centrolobular prominence. Oftentimes easier to see the centrolobular prominence when you use a thin reconstruction. So those are 3 millimeters, these are 1 millimeter, and you'll see that the ground glass abnormality and the centrolobular prominence of the ground glass abnormality is much more evident on these thin reconstructed images. If you are dealing with a lot of chronic lung disease and subtle interstitial lung disease, and you're not reconstructing images at around 1 millimeter thick, or perhaps even smaller, I think you're doing yourself a disservice. Makes it much more challenging to diagnose diseases. So it doesn't cost any extra radiation exposure, doesn't cost any more time really to send these thin reconstructions as well. Okay, so these are all CT findings of severe long-standing pulmonary hypertension. So that calcification in the walls of the pulmonary artery, the way I think of it is sort of like atherosclerosis. So you need very high, almost systemic-like pressures to cause that sort of calcification within the pulmonary arteries. And when the pulmonary artery is this large and has these areas of eccentric wall calcification within the pulmonary arteries, usually it's due to some sort of shunt, some sort of left to right shunt. Okay, so this is a two-chamber view from a cardiac MRI scan. These are cine images, obviously white blood cine images. And so this is a little off from a two-chamber actually. So a true two-chamber view, you should be seeing the LV, left ventricle, and the left atrium all lined out. But this was augmented a little bit, obviously, to bring out the IVC in here as well. So this is the IVC. This is the right atrium here. This is the left atrium here. See some of the pulmonary veins coming in. It's a little bit of a left atrial appendage. This is obviously the left ventricle. This is the mitral valve plane there. And we're seeing a little bit of the right ventricle in here. So we see this abnormal connection between the right atrium and the left atrium here. So this is the typical appearance, or it's hard to say it's typical because it's actually not that common. It's one of the lesser common subtypes of atrial septal defects, but this is a inferior sinus venosus ASD, which explains a patient's severe pulmonary hypertension. So let's go back to the lungs quickly. I have been asked multiple times, well, what does this central lobular ground glass abnormality actually represent? Because it is one of the findings of actually a post-capillary pulmonary hypertension. So I don't know if you guys have heard of this, but capillary hemangiomatosis or pulmonary capillary hemangiomatosis. And so this is a rare cause of pulmonary hypertension, which is post-capillary. And so one of the imaging manifestations there is the central lobular ground glass nodularity, as we're seeing here. Unfortunately, if you have long-standing severe pulmonary hypertension, you can also develop these areas of central lobular ground glass abnormality, which likely represent cholesterol granulomas as well as some foci of plexiform angiopathy. So the central lobular ground glass nodularity is not diagnostic of any single type of pulmonary hypertension.